Hello, my name is Elias Jabbour. I'm here from SOHO 2025 Houston, and I'm very fortunate to be joined by two of my esteemed colleagues and friends, Dr. Aldoss from City of Hope and Dr. Logan from UCSF. And we all here attending the SOHO 2025, and we had a great morning today dealing with ALL in depth, mid-expert session, as well as the general session on ALL. And as we all know, a lot of things are happening in ALL, and we made significant improvement in outcome, mainly due to multiple things: immunotherapy, MRD, CAR T cells, and transplant. And today I want to take advantage of your presence to ask some questions about how your practice is evolving and where the field is going. I want to start by you, Aaron. We know about you led a lot of work on MRD and immunotherapies. What is MRD today, and what should we know about it?
Well, I think MRD has become an essential component of managing all patients with ALL. Many of the studies that have been published still use flow cytometry-based MRD, but based on studies you and your colleagues have done and others that have done, have demonstrated real utility to the next-generation sequencing approach, so we have a deeper understanding. And I think that those data really suggest, especially now in the era where we have potentially curative non-transplant therapy, that we should be using the best available NGS MRD techniques so that we can really understand how our patients respond to their therapy and make the best decisions.
So that means, great, NGS should be standard of care, but when do you apply it? At what time it impacts your decision? Mm-hmm. And second question is, how the immunotherapy is revolutionizing the landscape of frontline therapy in AML?
Well, I think that with the current approach of using chemotherapy debulking followed by an immunologic consolidation with blinatumomab, it's essential to understand what the response to chemotherapy is, but also what the response to blinatumomab is. Your study with hyper-CVAD blinatumomab, the ECOG 1910 study, Dr. Aldoss and his colleagues have used 10403 with blinatumomab. It's really important to know how patients are responding to chemotherapy because the data from, for instance, ECOG 1910 show us that the benefit for blinatumomab really is in patients that have achieved MRD negativity with the chemotherapy. So we want to know at the end of chemotherapy, you can do it end of induction, you could do an end of first consolidation, but don't forget that MRD is now something that we can assess in serial fashion. So if we get it also after blinatumomab exposure, then we can make a decision that for those patients that don't have high-risk genetic features, if they're MRD negative after blinatumomab, we can largely avoid transplant. Whereas patients that have higher genetic risk, even if they achieve MRD negativity, we may still want to consider transplant because there's still some excess risk for relapse.
But that is high risk applies to everybody. There's certain higher risk higher than others, mm-hmm. Or are all. For example, if you have high risk, you do blinatumomab therapy, you're NGS MRD negative and 10 to minus 6, especially if you respond early on after one course of blina. Will that overcome the poor biology, or still we don't have much data, we should go for transplant in all comers?
I think we're starting to see some suggestion that blinatumomab will overcome the genetic risk in some patients. So in subset analyses from ECOG 1910, we see that patients, for instance, with PH-like disease, very, very high risk, if they're MRD negative after chemo and remain MRD negative after blin, they can do well largely without transplant. But it's a small number of patients, and transplant has by and large been the gold standard for these very high-risk patients. And so I think right now to potentially remove a curative therapy, we need a little bit more data, and you and your colleagues are working on that, as are other groups around the world, to really help us better select the high-risk patients, even the very high-risk patients where we can avoid transplant. Because even though we're transplanters, we would all love to transplant fewer patients.
Then we talk about transplant and transplant. Show me the opposite. I want to use MRD to de-escalate rather than escalate therapy. Can we identify a patient, for example, in whom we can shorten therapy? We can do 6 months or a year or less than 2 years. I don't know, but are we in an era where we can use MRD to tailor therapy in both ways, escalation and de-escalation?
I think so, yes, because on the ECOG 1910 study, we see that the standard risk patients and the intermediate risk patients do phenomenally well with chemotherapy and blin, nearly 100% survival for both of those groups. So that really is an opportunity to de-escalate therapy, particularly in those achieving the deepest remission. So I think that's where we need to go, and this is really an essential question worldwide, because in many countries, they simply can't afford to give 4 or more cycles of blinatumomab. Many are already giving only 2 cycles, and they're giving shorter cycles of blin. So I think it really is an opportunity for us to learn and help other countries optimize their use of the most effective therapy by de-escalating in future clinical trials.
That's very informative. Now, when I go back to the MRD, the standard of care, patient who had, for example, any induction therapy, be it CLGB10403, hyper-CVAD, or any backbone, they don't have major risk factors, but they're MRD positive by flow or by NGS. You give them blinatumomab, and they convert into MRD negativity. Is transplant needed for these patients?
Right now, I would say we can probably avoid transplant for those patients, but I do recommend serial monitoring of the MRD, and if they have an MRD progression, that's your opportunity to intervene.
And if you avoid transplant and you do serial monitoring, do you give some form of maintenance therapy with a blinatumomab or others?
Well, I think that if you're not following a transplant protocol, then I would follow consolidation and maintenance. I do think there's an opportunity, especially to remove or shorten maintenance. You and your colleagues have already done some studies to try and do that. But on many of these trials, we have not seen late relapses during maintenance, which I think is suggestive that maintenance may not be necessary. So we should wait for clinical trials to make a change in the standard of care, but I think that's really where we should be headed.
Speaking of transplant, Ibrahim, I know you are a big transplanter, and we agree on everything sometimes except for transplant in certain scenarios. In 2025, what are the indications for transplant as standard of care?
Now, I would say, first, again, I'm a transplanter, but again, we also aim to reduce the number of patients who need transplant because we acknowledge that transplant has long-term complications and can impact quality of life of the patient. And we are seeing actually we're transplanting less and less BCL ALL patients, younger and also older pH positive and pH negative. Now, transplant is still indicated, I think, for high-risk disease. And high risk is combination, I think, of biology of the disease as well as the MRD kinetic response. And we take both into account. Patient, let's start with pH positive ALL. We still can advocate to transplant IKZF deletion plus patient. Patient who had persistent clonoSEQ after blinatumomab, we tend to transplant. I know the data for ponatinib and blinatumomab, it doesn't seem actually IKZF deletion plus matter, but I think we need to see longer follow-up for pH positive ALL. For pH negative ALL, there are still high-risk features, genetics like pH-like ALL. They will declare themselves that they're high risk by having persistent MRD by flow and by clonoSEQ frequently. But for those who achieve early MRD negativity, especially by clonoSEQ, I think you can avoid the transplant in some subset of these patients who don't have the CRLF2 rearranged leukemia without JAK2, those without EPOR or JAK2 fusions. Potentially can avoid if you achieve clonoSEQ negativity with chemotherapy and you incorporate blinatumomab consolidation in that setting. But also you have the KMT2A, the haplodiploidy and TB53, and the concern of TB53 patient, they develop therapy-related MDS, AML, CD19 negative relapse after a blend.
You mentioned the KMT2A ALL, which is something quite aggressive, and we have a lot of trial with the menin inhibitors. Can you give me some hint about where you see the treatment in ALL for this subset is going?
Yes,
besides transplant, of course.
Yeah. We have actually, there's going to be a cooperative study, group study, where we incorporate actually menin inhibitors with the frontline treatment in older patients as well as younger patients, including children. And the study we have designed actually where we actually randomize patients in CR1 MRD positive after induction or consolidation to either blina plus minus revumenib in younger patients. And for older patients, we're incorporating revumenib as part of the induction therapy and along with the consolidation with blinatumomab. Now, it's still too early to kind of see if this approach can actually cure more patients without transplant approach. Until we have more data, I think transplant is still indicated.
Yeah, of course, I'm not questioning transplant, but imagine for this subset, like it was pH positive transplant the only way, and we give a blina ponatinib. Can you imagine giving sub-Q blina plus revumenib or any menin inhibitors and improve the cure. That will be.
Yeah, I think
dream
this
come
is the
true.
future. I mean, the issue with CD19 target therapy in KMT2, as you know, it is the lineage switch. But the hope with menin inhibitor, with kind of more
You can
potent
eventually-
immune therapy, potentially can cure these.